This week on the BackTable podcast.
Maybe it's an opportunity, though. I think all of us are pretty frequent blue light users.
Yeah.
And I think that that's where I think...
That's a biomarker, right?
Enhanced cystoscopy is another biomarker.
Yeah.
I consider it a biomarker. I think in those high-risk patient populations, I definitely fall back on using that to make sure I'm not missing anything. My personal preference is for patients, especially if they have a history of carcinoma in situ, after induction BCG, not at the 3-month cysto, but at the 6-month cysto. That's a for-cause. Go to the operating room with blue light, random biopsies, make sure we're not missing anything.
Welcome to BackTable. I'm Vig Packiam, and I'm super excited to be joined by two amazing superstars, Dr. Sarah Psutka from University of Washington and Dr. Katie Murray from NYU. Do you want to give the audience a quick introduction?
Sure. Hey, thanks so much for having me, Vig. So I'm Sarah Psutka. I'm a urologic oncologist at the University of Washington, and I'm particularly interested in research that really focuses on sort of understanding patient-specific risk and how that can inform and really gathering priorities of patients to help inform shared decision-making. I've recently gotten into running trials in the prehabilitation space, so very different from what we're talking about today, but actually some kind of similar overlap in terms of trying to understand how we do a better job of risk adapting our care to the oncologic threat in front of us.
Perfect. Katie?
Yeah, I'm Katie Murray. Like you mentioned, I'm from NYU Urology. I'm super excited to be here, chatting with you guys and trying to give some knowledge, but learning from you both at the same time, right? As we kind of explore this new idea of biomarkers in non-muscle invasive bladder cancer, right? And I think, Sarah hit it spot on as we have these broad range of patients, and patients are really looking to us and asking for the best answers. And, we have all of these tools and figuring out how and when and why to use them and pass that on to our patients, is so important. So super excited to be here and learn a little bit at the same time, or
Great.
learn a lot.
Yeah, that's a great introduction. So it's a really exciting time for non-muscle invasive bladder cancer because for the first time we have biomarkers that may be able to let us do precision medicine or may actually let us tailor surveillance a little bit more. So Sarah, do you want to kick this off? Tell us a little bit about the traditional biomarkers that are described for non-muscle invasive bladder cancer, maybe the FDA-approved options, and are these ones that you use in your practice?
Sure. So I think, of course, we have to talk about, we'll call it the OG, which is cytology, right? Cytology is the biomarker that we all use in clinical practice every single day. The tricky bit about urine cytology is it is not actually a great biomarker. It can miss a lot of low-grade cancers. It's pretty good for high-grade and CIS, but it's definitely not perfect. And so there were sort of these legacy biomarkers that were developed, many of which have an FDA approval, that have been around for a while. And I think that we can sort of break them down broadly into two groups. There's the urine-based biomarkers, which are essentially urothelial cells that have been, they call them exfoliated, which basically means they're floating in the urine. And I think probably the one that most people are familiar with is Eurovision FISH. So that's looking at chromosomal abnormalities and or what's aneuploidy in a couple of different chromosomes. It does require some specialized equipment to utilize. It is included in the AUA guidelines, and it can be used to adjudicate a cytology that's positive or that's a cytology that is not positive, but that's atypical or suspicious. And it sometimes can also be utilized, and they say this in the guidelines, that we can use it to assess BCG responsiveness, which I think shows one of its utilities. But it, again, does require some specialized equipment, and it's quite expensive. Immunocyte is another biomarker that can be used in this space. But then there's also the protein-based biomarkers, and most people are probably going to be familiar with NMP22. And so what that is, and there's two different sort of forms of that. There's a version that actually assesses the amount of this protein, which is nuclear matrix protein 22. When bladder cancer cells die, this protein is released preferentially into the urine. You can actually measure the total amount, a quantitative amount, or you can just do a spot check, and that's the bladder check, which is a point of care test, which can be useful. The tricky bit with the protein tests is if you're just looking for these proteins that oftentimes are going to be found in higher proportions when bladder cancer cells die, is that there's a lot of reasons why you might have false positives. So for example, you're going to see higher levels of those proteins in settings where there's a lot of inflammation. in settings where there's potentially infection, and especially relevant to all of our practice, and in folks who have just been treated for bladder cancer with, for example, BCG. And so it ends up being a little bit more challenging to use those tools in practice. And I think what we end up seeing is just a lot of false positives, and that can contribute to a high degree of anxiety and uncertainty. And then we were chatting about this before. I think I end up seeing a lot of referrals for positive biomarker tests in the absence of clinically identifiable disease. And the question is, well, what do we do with that?
Yeah, that's an awesome primer.
Yeah, I think, you kind of brought it up. So I'll say, I think all of us work in referral centers, right? So you do have these patients, come in, and a couple of different things happen, right? Patients have maybe a suspicious or an atypical cytology. Their in-office cystoscopy by their primary urologist was negative, and, they have a positive fish or something like that. And then they come to you and they say, what do you do about this? And what are we going to do? And so I think, when I see things like that, really, even like talk to my residents or the medical students, right, is to start fresh, right? This patient has come into you as a referral, and make sure you've looked from top to bottom, right? Make sure they have an updated CT urogram or MR urogram, whatever is able in your, preference. I always repeat cystoscopies on these people. I repeat my own cytology. I don't use a lot of these biomarkers, but I do have to incorporate them in my practice because the patients show up with them, right? Or another scenario is a patient who has followed with another urologist at some point in time historically, and they come and they say, oh, wait, you're not going to do my NMP22, or what about that spot check bladder, test that's approved? I've had that for 10 years with my other urologist. You don't do that here, right? And so it is important for us to kind of understand what that is. And there are reasons that could be very useful for people in other practices. But I think personally, I don't use some of those point checks, point of care testing for some of the reasons that you talked about, is kind of that shedding, see results with inflammation, infection, prior pre-treatment, and these are older men, larger prostates, they're voiding against that prostate. You'll see some inflammatory response, even with that alone.
Yeah, I agree completely.
Yeah, I think of those traditional biomarkers, I think fish is probably the one that people are most familiar with or see around. And one of the main roles of it is to adjudicate, atypical or suspicious cytology. But personally, if you have blue light cystoscopy, I think that's a good alternative to using that to hunt things down rather than another test.
I couldn't agree more. And I think also, we're going to talk a little bit about sort of, we also know that bladder cancer is one of the most expensive cancers. And adding these biomarkers when we do have perhaps a more effective diagnostic test that can be done in tandem with our white light cystoscopies. I think that from an efficiency standpoint, we have to think about when we kind of fall back on these biomarkers versus kind of, I agree, now that we have blue light, enhanced cystoscopy in my hands is much more useful, I think.
Yeah, absolutely.
So, shifting gears, these are the ones that are available now. If we're thinking about new biomarkers, do you have a good way you kind of keep them separate in your mind or organized?
Yeah, I think biomarkers, obviously, across all cancer types, right? That's what patients are coming and asking us for, right? They just don't call it by biomarker. They all want these tests. And so I think Sarah kind of mentioned it when she, said it right from the beginning, is urinary-based tests versus tissue-based tests and biomarkers and what that means. And so I think, dividing it out that way is an easy way to kind of consider, right? Is this a patient who has been diagnosed and you need to continue, and you use that tissue diagnosis, with immunohistochemistry, right? We're probably have no doubt in my mind that our conversation is going to get into AI at some point over the next bit of time and what that means for histology and pathology. And then, of course, urinary-based markers, right? We say it all the time, when we talk about bladder cancer, is that the fact that we have urine all the time, right? It should be the most magical thing ever. Unfortunately, as we just mentioned, we haven't found that perfect biomarker yet that is urine-based.
Yes. Well, that's a really good overview and a good way to kind of keep track of things by looking at where the test source is coming from. So, you talked about, the OG traditional marker being cytology.
Yeah.
I think one of the kind of the OG markers for these next generation tests is Decipher Bladder.
Absolutely.
It's been out for a while. It's been approved for T1 through T4 cancer. most of the data, to my knowledge, is for muscle-invasive bladder cancer, but are you ordering this for T1 NMIBC, and how are you using it?
Yeah, so great question. I think that biomarkers are really important and really going to ultimately change how we practice, especially as we move. We're I think, increasingly moving towards a precision medicine-based approach, especially in bladder cancer. To some degree, maybe more so than most of our tumors, especially as we're starting to really understand these different genomic profiles. So when I talk about the OG genomic biomarker, that is the Decipher Bladder Genomic Classifier. So what are we looking at there? We're looking at 219 genes that are obtained from tumor tissue. Okay, so this is a tissue-based biomarker, to go back to Katie's really nice way of sort of thinking about how we break these all apart. But the idea here is that the classifier essentially groups bladder tumors into one of 5 groups. And these are these molecular subtypes. And I think we classically think, so you think about the luminal, infiltrated, basal, claudin low, and neuroendocrine-like. The point of this is that once you've classified the tumor into one of these 5 groups, we do know a lot about how they behave. And I think I'm going to take a fairly simplified sort of high-level approach, because I think getting into all of the nuances of each of the 5 subtypes is a bit challenging. But I think an easy way to think about this is that luminal tend to do better. The non-luminal tend to do worse. And there's some really nice work recently that has shown that the non-luminal tumors, not only do they progress more quickly, but they're more likely to be upstaged. And I think that's what you're getting at, Big, which is that there's a couple of studies recently, and then there's actually a 2025 paper that just came out in European Urology Open Science that was led by Yerlo 10, that in a multi-center study demonstrated significantly increased risk of upstaging in patients who had T1 to T2 tumors that then where the non-luminal tumors were upstaged. So I think that the question there is, can you use this to identify those really high-risk T1 patients who maybe you should be thinking about a radical cystectomy as opposed to an organ preservation sort of strategy up front? I'm not personally ordering it myself as of yet a lot. I think that there are some, this is approved and it's covered by Medicare, but there are some barriers to using it in clinical practice. And I think that different clinical workflows, one of the places I practice is in a county hospital. And I think there are some challenges to utilizing some of these tools in different clinical scenarios. But I think that this is definitely a classifier that has clinical utility if your workflow allows you to use it.
Yeah. What about you, Katie? Are you using it?
I'm not using Decipher regularly, and I haven't used it. Sitting here listening to Sarah talk about this, and I'm thinking and taking a step back, right? I don't treat prostate cancer now in my practice, but as I think about this and I think about Decipher and how you just described that for bladder, and really kind of that tipping point of pushing a patient to something more radical versus, a more sparing type of approach, whether that be for a T1 tumor or a T2 tumor, right? In a bladder sparing kind of concept, right? I think our prostate colleagues were having this exact conversation not that long ago, and Decipher is very well gotten into the guidelines and really is helping them with that tipping point and making an impact, right? And so sometimes patients need maybe another piece of information. So as I'm sitting here listening, I'm thinking, okay, I don't use it personally, and I'm not sure that I would use it across the board on all of my T1 or all of my T2, even for that matter, patients. But there are those patients that for some reason, high-grade T1 with concomitant CIS, LVI, right? I have no doubt in my mind, my gut tells me that's bad. If I had another piece of information, which Decipher could give you, luminal, non-luminal, simple, black or white, it might help me have that conversation with patients a little bit easier. And I think that's the cool part about it, honestly.
And I think the other piece of it that I think is really interesting about the Decipher literature, maybe its potential utility in helping choose treatments, is the luminal tumors trying to avoid neoadjuvant chemotherapy. Because as much as we think about when should we be escalating care, I think we also have to be thinking about when can we de-escalate care, when can we avoid an unnecessary treatment that maybe isn't going to benefit a patient. So I think that actually is incredibly compelling, and it would be a reason that I actually might be, especially after sort of deep diving all of this literature, thinking a lot more about trying to figure out how to integrate this into practice, because I think there's some real benefit there if you can avoid the toxicity of unnecessary neoadjuvant treatment.
Sure. I'm glad you brought that up. We didn't plan that discussion, but My partner is actually running an IAT that he's hoping to start in the near future, randomizing patients with luminal subtype muscle-invasive bladder cancer to upfront cystectomy or neoadjuvant chemotherapy and then cystectomy.
That's great.
To do that exact concept.
I mean, that's the kind of work that we really need, because if we can get level 1 evidence that really answers that question. I mean, I from all of the different studies that are out there that this is the association that has been drawn thus far, but definitely trying to understand sort of like algorithmically how we can actually use this to change our decision making, I think will be very helpful.
Yeah. We have some early research looking at additional molecular data run from their platform to see if we can make new subtypes specific to non-muscle invasive bladder cancer.
Oh, interesting.
Because the 5 that you mentioned, most of that data is from muscle invasive bladder cancer. But is there something different for NMIBC that could maybe guide you to the right treatment within NMIBC?
Yeah, super interesting.
We're going to continue to get into it, right? But, in NMIBC, who should be getting BCG? Who should be getting intravesical chemotherapy? Who should be getting anything else? The laundry list of things that are coming. Super exciting, right? And so we have to make those decisions.
Yeah, we have some early data from Iowa where we took patients with NMIBC who got either BCG or gemdosi, looking for some of these signatures, and we found an immune response signature that was able to predict if patients would have poorer response to BCG but not gemdosi. So we need bigger studies to look at that. But
we're jumping around a little bit, but I think it's fun. This is what we do. I think we can't help ourselves, right? But it's the conversation you have with patients all of the time. Do I believe that BCG is the perfect thing for every single person? No, I believe that your tumor, BCG can work very well with. Your tumor might be a chemo tumor. Yours might be something else. If only I were smart enough to put those, and line those up with the correct person, our world would be a much better world, right? Our bladder cancer world. We're getting close, I think, right? We're gonna talk about some of those things, but unfortunately now we kind of go through these regimens and do what we do and work our way down the list.
So Sarah, pivoting a little bit to IHC.
Yeah.
So we do IHC testing more for kind of advanced cancers that need targeted therapies, but are you doing any IHC testing for NMIBC, PD-L1, those types of things?
Yeah, good question. So PD-L1, no, or HER2, no, although some of those immunohistochemistry stains, I think, obviously, we're going to start to see, I think the one that we do use is FGF alterations. I'm not really using it in clinical practice yet. I'm using it to get people onto clinical trials. So just let's take an example of the Moonrise platform, right? So the TAR-210 device that elutes erdafitinib, which is a pan-FGFR3 inhibitor or pan-FGFR inhibitor. So obviously to get on those studies, you need to understand the alteration pattern in that receptor. And so I think that's where I'm using it right now. But I bet you as we start to see where the efficacy of these different devices, I wouldn't be surprised if we start to do IHC much sooner. The place that I really order it is actually when I'm screening for Lynch, obviously in our upper tract population, which both Kathy and I do a lot of. But in general, right now, it's really to get people on trials. And I do think it's interesting, even in the advanced space, like the PD-L1 sort of patterns, they haven't borne out in terms of helping us understand who's really likely to benefit from immunotherapy, with the exception of a couple of trials. So I think at this point, probably too early for prime time, but great in terms of helping people get on trials.
I'm curious always, if somebody thinks out in practice, like, oh, I just want to start doing FGFR, right? A little bit of curiosity. What does that look like in trying to do that, right? I have a GU pathologist, so I can shoot a couple, messages in the Epic chart or shoot a couple text messages and do things like that. But what does it look like if somebody said, I really want to start doing these IHC screenings, in my NMIBC population? Do either of you know in your practices or how complicated is that?
I mean, I know that there's multiple ways to do it.
Sure.
And I kind of leave it to pathology or, for Moonrise, the trial kind of mandates how they prefer to have it done. Right. But it's a really good question. Even something as simple as looking for one mutation, you can do it 5 different ways.
Yeah, totally. I do think it's interesting too. The one thing that's from a trial perspective, I think we we all have a sense, or we think we know what the prevalence of those alterations is going to be.
Yep.
And what's really interesting is when you start testing everybody, you actually see that it's very different.
That's right.
And that's been to the detriment of some trials where you're just not finding these eligibility criteria, gene alterations being expressed at the levels that we think they are going to be. So I think it's going to be interesting as we move forward to actually get a better sense of what the sort of epidemiology of those gene mutations truly is, as opposed to when we're sort of using convenient samples.
I think so.
FGFR is a perfect example because in the literature, it's anywhere between 30 to 70%, which is flipped.
For NMIBC.
And I think in our hands, it was around 50%, but we're going to learn more about it as we do it more.
Totally.
So,
but I think we're in an era also, as I always take a little bit of caution very early outside of trial to putting these new things into your practice, because the patients are on the other end of it, right? And when you're looking for a potential targetable mutation in their tumor, but then you don't have anything to follow up to offer, because it's not part of a clinical trial or something, right? That's a complicated conversation for people, to have with our patients. So I personally would take a lot of caution in just pan scanning people for this, right? In 5 years, I might pan scan everybody, and that might be, what pathology does for us. But, it's exciting and interesting, but caution in clinical practice because it can backfire on us sometimes.
That's probably a really important point to hammer home. Just because you can doesn't mean you should.
That's right.
Especially when we don't know what to do with the data. But if you have when you have a reason to, if knowing versus not knowing is going to change what you're going to do, then you probably should be thinking about how do I establish workflows where this is easy?
great point. Yeah. Is it going to change management?
Yeah.
The classic question before you order any test.
That's right.
So
100%.
diving a little more into pathology, there's some exciting new AI tests out there, and I'll disclose, I've done a lot of work with some of them, but what do you think about some of the data for these AI tests? And is that something that you're ordering in your practice?
Yeah, so I'll be honest, I haven't ordered it in my practice just because of the workflow of physically getting it ordered, right? Because it is AI and it's patients' tissues, and how do you physically get that through your institution and make sure all of everything is checkboxed appropriately. That being said, the data is super exciting, right? And kind of goes to what we talked about, right? For example, Valor Labs, is out there and trying to looking at prediction of response to BCG, right? That data was reported almost 2 years ago, I guess now, the initial kind of data looking at high-grade recurrence-free survival, progression to muscle-invasive bladder cancer, in this NMIBC high-risk population. I think those are all the questions that we ask and we're trying to portray, to our patients. More recently, right, that just got published within the last, or reported out, I should say, in the last couple of months, is really looking at that high-grade TA population. And I think that's a population that is a little bit of a struggle sometimes, right? And especially even if we look back at what our guidelines tell us, that's the population that changes the AUA versus the European guidelines in how people think about high-grade TA disease, and, kind of looked at those recurrence-free survival type of outcomes and significantly had an impact on that for that high-grade TA population. So I think that's super promising.
Just to press you a little bit more on that,
sure.
What kind of data would you need to see to think it's reasonable to use? Do you need prospective data, larger retrospective data sets?
Yeah, so I think larger retrospective data sets is the natural way to get there, right? We have all of these patients, we have their outcomes, and we know what has happened to them, right? Can we retrospectively look back and predict, that they were going to be a responder, were not going to be a responder to BCG or gemdosi, for that matter. So I think that is definitely the first start, but I do think prospectively watching this along and doing it in real time would be super exciting.
I think the risk stratification piece is super interesting. So the Sam Chang paper that just got published in European Urology I think it was like a cutting edge communication, just a short piece. And I believe they discussed it at the AUA as well. If you can better adjudicate risk with this, and it outperforms both the EAU and the AUA risk stratification tools in contemporary practice, I think that's really an important point that we should all be aware of. And I think this data actually, we need to understand, we need to see where this goes. Because if you think about it, all of our decision making in non-muscle invasive bladder cancer is based on the risk stratification. And if those tools are one of the tricky bits of all of that, and I think Ashish Kamat has done a lot of writing on this, is how those risk stratification tools are based on older cohorts of patients that are somewhat historical at this point to some degree. We probably need to be thinking about how we can kind of update our understanding of who goes into that very risk category, who goes into the low risk, thinking about better understanding, the intermediate risk space, absolutely. I'm a big proponent of the IBCG, sort of fairly nuanced re-stratification of intermediate risk into 3 risk groups of its own. But if you can use this to understand, if you can add the computational histology, artificial intelligence score on top of that, I think that's something we need to really think about how we utilize. But it's going to be really important to follow those patients out and see how it happens, how it goes prospectively. But the retrospective data is super promising.
Yeah, I personally am ordering it. Their report kind of spits out 2 data points now. One is kind of a prognostic marker where it gives you a more tailored estimate for 2-year recurrence-free survival compared to traditional clinical pathologic features. I like the numbers. I think sometimes patients really like hearing you have X% chance of cancer coming back or being cancer-free at a certain time point. So to me, that's interesting. And then the other kind of more provocative thing is, are there some patients where BCG may not be the most optimal first choice? Something else like gemdosi or clinical trial may work better for those patients.
Have you had any difficulty getting that into your workflow, or are the patients seeing any charges from that? Like, what are the cost implications of that?
Great question. It's one of those situations where once the hospital has it integrated in their workflow, it's pretty seamless from there. You can either send one H&E slide to the company or send digitized images. Most of the time, sending a slide is easier because that's how we do a lot of other tests. For the most part, it's covered, or patients aren't charged, but it's something we have to keep watching for.
Yeah. And are you doing it on a research protocol, or you're just using it in clinical practice now?
Both.
Okay.
Yeah, depends. It's approved for high-grade disease.
Right.
For low-grade disease, we'll do it on a research protocol.
Yeah, super interesting.
Are you, right? So the data came out, and I think you were part of it in AUA, of that positivity. So if they had the CHAI positive versus CHAI negative, and the higher recurrence-free survival with gemdosi versus BCG, right? Like 70, upper 70s versus 50s. You probably know the data, but about 76 versus 52 or something like that at 2 years.
20+% difference.
Are you using that and treating patients with gemdosi versus BCG based upon your AI positivity?
It's a good question. I think if you
can we do that?
Yeah, I think if a practice has unlimited BCG, it's kind of a moot point to explore other options until trials like Bridge end up reading out. If you have no BCG, obviously, there's not a lot of decision making there either. But I think the reality is most practices have some low amount of BCG that you have to ration. We have SUO guidance on how to optimally ration that. But if you want to take it to another level and have another data point, I think it's a good thing to consider adding. So not completely ready to be used exclusively, but I think it's one more good piece of information.
So you're using it almost in your triaging of BCG, right? So at our institution, right, we triage BCG because this month we might be great, next month we might not be great, right? And so we kind of came together, and I'm the triager of BCG. Basically, if you have a new patient, you want to give BCG in our practice, you send it to the nursing, and then it comes through me. I review the chart and say, okay, this patient comes above this one or below that one, and kind of triage it out. So that would be a potential additional piece of information to help me put.
Absolutely, because otherwise sometimes there's not a rational way to triage. I mean, how are you going to differentiate one patient with T1 disease versus another?
Yeah.
And why not use extra data for that?
I think that's, especially in the current environment, super important.
All right, so moving on, ctDNA, I guess the OG of that is Signatera. And recently there's been some really interesting provocative data from Laura Bukovina published in European Urology. Can you tell us a little bit about that, and are you using that test in your practice?
Yeah, good question. So ctDNA right now, obviously, I think it is probably the biomarker that's got the most sort of astronomic trajectory course. It's being used so so much more extensively in the metastatic space. It's definitely, I think there's a lot of interest in how we can use it in the muscle invasive space to understand minimal residual disease and start to think about how we can use that to help us understand who gets adjuvant therapy versus not. And then, of course, if we're getting into bladder sparing, which we're not even going to have time to touch here. I mean, there's a lot where ctDNA is, I think, really clinically going to become very relevant very soon, if it's not already so. But Laura's paper, I think, is really interesting. So she's been ordering Signatera testing on patients with non-muscle invasive disease. And this is, again, a brief communication, 23 patients. But basically, the punchline is, in this study, in a couple of patients, it helped to find disease sooner. And it was anticipatory. So a positive Signatera test in the non-muscle invasive space, what was interesting was that she actually had positive tests. And I want to say it was 35% of patients. So about close to a third of patients of this 23 patient cohort, a small cohort, but over that amount of time, a third of patients had positive ctDNA in a non-muscle invasive cohort, which first of all, gives us all pause. And so how did it change practice? She mentions that in one patient, she ordered testing sooner, and it did change management in terms of pushing one patient towards a cystectomy. So I think it's super interesting because, again, in the non-muscle invasive space, there's this massive tension between escalation and de-escalation of care because we know that some proportion of those non-muscle invasive patients are going to be lethal. Those tumors are going to be lethal. The patients are going to be facing the risk of what I call a never event, which is you have non-muscle invasives like CIS that then becomes node positive. And all of a sudden you've lost your window of opportunity and you're not talking about a straight up upfront cystectomy or even neoadjuvant cystectomy. You're talking about full dose chemotherapy and then hoping you get to cystectomy. So I think that this is very provocative, extremely interesting to think about. But here's the other question. What do you do in the patient that you have a positive test and you can't find disease on? And I don't think we have the answer to that yet. So I think that this is a really, I am, to answer your question specifically, I'm not currently ordering Signatera testing in my non-muscle invasive patients. At our hospital, mostly the medical oncologists are ordering it within the context of our multidisciplinary clinic for the muscle invasive patients and starting to use it to think about whether it helps to guide adjuvant treatment. But I do think that this paper, and I do have patients asking me about it, this paper is definitely going to, I think, sort of potentially encourage more widespread testing. I think we have to think about how we're going to use that data.
I thought the numbers were interesting in that paper. A third of the patients had positivity. We've ordered it, maybe 10 times, and I don't think I've had a single patient be positive. Right. I also found it a little interesting compared to historical cohorts where early cystectomy was done more often, like 20 years ago. Mm-hmm. Usually node positivity in NMIBC is less than 10% as a whole. So these numbers seem a little bit high to me, and I worry about false positives.
I agree. And I think she makes the point in the discussion that it's a very highly selected referral-based population. So you have to take that context into account. I mean, even if you look at the BCG unresponsive CIS patient population who have been through multiple rounds of organ-sparing treatment, their node positivity rate should be somewhere in the 6 to 9% range. So this, I think, is a very select group of patients. But in patients who did not have evidence of muscle invasive disease at the time when this testing was ordered, to have a third of them have positive ctDNA, I think is interesting.
Yeah. I think if I had a patient who I really thought cystectomy would be the best treatment for, maybe multifocal T1 and CIS, LVI, maybe some micropapillary, then getting it seems interesting, but maybe not for the bread and butter. Yeah.
I think we need to be very careful not to be this is not something that I would be ordering in someone with intermediate risk disease. This would be in the highest risk patient population.
Absolutely.
Yeah, definitely don't want to be chasing our tails for an intermediate risk patient, right?
Agree.
Recurrent low-grade disease, ctDNA, it has no role in today's world in my mind. So I think that's a really good point to make sure is clear.
Mm-hmm.
So you mentioned UTDNA, urinary DNA.
Sure.
There's some new studies coming out with Predicin, UroAmp. They're getting integrated into some clinical trials. Do you think that's a promising avenue, and are any of that data exciting for you?
Yeah, so I think the data is very exciting in the fact that they're just getting out there and collecting data and putting it into clinical trials, right? I think I mentioned earlier in the conversation is that These are bladder cancer patients. Urine is right there all the time, and we are collecting urine at so many points, right? These patients, if they're having BCG, they're in every single week for 6 weeks, and then you're having the follow-up cystoscopy. So the idea of using a urine-based test makes complete sense. I definitely don't think, there's not been any real data out there that makes me think like, oh, I'm going to start ordering this on my patients, because I just don't think, there's been any reports of sensitivity, specificity that are there yet compared to what we already have. But, I think the big ones that you mentioned really over the past 2 years that have come out is UroAmp and Prednisone. There's some other word that comes after Prednisone. I don't remember what their company's called exactly, but
Yeah. Excited to see where that goes. And I think philosophically, it makes sense to try to look for something in the urine. We've always been hurt by sensitivity, specificity characteristics. So hopefully that can get sorted out.
But I think one of the potential benefits of the UTDNA is that it's going to overcome the problem we have with protein-based biomarkers, which is where you have the contamination from inflammatory processes, because it's a much more specific test.
Truly the DNA.
So I think that if we can I think you will see once those tools have been validated, I think they are going to rapidly sort of outperform and take over what we have been using, which is more protein-based.
Yes, 100%.
Yeah, that's a good point.
So we've been talking about risk stratification for patients that are diagnosed. Let's switch gears a little bit, talk about screening. So most of us as urologic oncologists see a skewed population. We're seeing patients that are already diagnosed with bladder cancer, but let's step outside of that for a moment. If you're just looking at screening patients with either microscopic or gross hematuria, traditional workup is CT urogram and cystoscopy. Are there markers that are exciting in your mind that could replace this or change our screening pathways?
Yeah, and I think this is actually an area that I am really interested to see if we can start to use biomarkers to empirically direct our screening procedures, because we know that, let's just take microscopic hematuria. We know that at most we're going to find bladder cancer in 5% of patients with microscopic hematuria.
High number in my mind that I would tell patients.
I would say it's probably closer to 2% or even less than that. So we are doing, and even if I love the new AUA microscopic hematuria guidelines that allow us to risk stratify and be a little bit more thoughtful about who we put through CT scans and who we put through cystoscopies. But we are still doing a lot more scans and cystoscopies than we probably need to do, and even with gross hematuria. And so there are a couple of tests that are being evaluated to see how they can guide our screening procedures. And I think the ones that I think about are that there's actually some pretty nice recent publications on. So there's the CX bladder triage, which is 5 mRNA. It's a genomic test looking at the expression profiles of 5 mRNAs. But the cool thing about this is it actually has some clinical questions too. And it gives you a score out of 10. And if it's less than 4, you got a very high. So I think it's 95% sensitivity and a negative predictive value of 98.5%. And I'm looking at my notes for that. But I think this is important because, so if you think about it, when you have a screening test, what are the key characteristics of that? You've got to be sure, this is a rule out test, right? It's if you're saying, based on this test, I am not going to do the gold standard evaluation, then I need to be darn sure that I'm not going to miss a cancer. And so these tests really prioritize the negative predictive value. So you make sure that you actually are not missing. If it says it's negative, there's no cancer there. And so there's a nice paper that recently demonstrated that you actually could use this in clinical practice to potentially reduce the need for cystoscopy in patients who were low risk by the AUA risk stratification. And then there's another tool that's been evaluated in an Italian sample recently, and that's the Expert Bladder Cancer Detection Test. It's another mRNA-based test, another 5 different mRNAs that are being evaluated. And then actually NICE in the UK uses ADX bladder, and that's an ELISA that looks at, it's called mini chromosome complex component 5, which is a cell proliferation biomarker. So the idea with all of these is that you basically have a test that allows you to better inform whether or not there's a very high likelihood that there's a cancer there or not. Now, ADX bladder is not supposed to be used without a cystoscopy, and the current guidelines do not say that we can use any of these tools without the cystoscopy. They can't supplant it. However, I do think it's kind of interesting that we're starting to see these very high negative predictive values that then would allow you to be a little bit more thoughtful about whom you might be able to avoid cystoscopy in, especially in that low-risk patient population.
Yeah. That's a really good point. And right now we're using them in conjunction with cystoscopy. So I guess to take it to the next step, do you think any of these markers could allow us to skip cystoscopy? And is that something that patients actually want?
Yeah, so I think, for the appropriate patient, for the patient that really dreads that cystoscopy, that absolutely, right? There's probably the capability to do that, right? Negative predictive value of 98%. Are we okay with that as urologists? I think even if we looked at what our guidelines recommend, I think a 98% is congruent with what we would say. So I think the answer is yes. And I think patients are hit or miss, right? Meaning these patients, we have instilled in them, a patient with non-muscle invasive bladder cancer, that cystoscopy just becomes part of life, right? I have preached that from the first diagnosis, that we are going to be friends, that every 3 months, or eventually it comes out to every year, that we're going to be having this cystoscopy. They don't love it, but it's a very tolerable procedure. And unfortunately, they get used to it, right? And so for that population, there also can be some comfort for those patients to see that negative result, right? They are looking at the screen on the cysto right there in your office with them. They know what they're looking for. They see something, they go, oh, or, oh, it looks really good. Don't you agree? Right? They're kind of interpreting it at the same time that you are. And so I do think that if we were to start replacing cystoscopy or think about replacing cystoscopy, some of those early conversations that we have with these new patients is, we have to incorporate that, pull a little bit of cystoscopy out of it. So I think there are patients that would love for me to say, I don't have to do cystoscopies, but twice a year instead of 4 times a year. But they would also ask the caveat, but do you think that's okay, Dr. Murray? Are you sure you wouldn't want to just go ahead and look? Because I know I complain, I'm not totally opposed, right? So I do think that they have a few caveats in that. But from a big population, absolutely. The more that we can decrease the need to do those cystoscopies in our office saves us time to be seeing other patients and doing other things.
Yeah, I totally agree with that. I've seen that too. And I was surprised when I started my practice where patients with high-risk cancer that have received, all these intravesical therapies, they're very interested in getting the reassurance from a negative cystoscopy. It'll take a lot more to have a marker that's good enough to replace that in that situation. So, are there certain risk strata that you think are the best ones to initially focus on if we're trying to get rid of cystoscopy?
Yeah. So I think, the high-risk patients, unfortunately, 4 cystoscopies plus a year, because at least we know that over 5 years, many of those patients will need up to 3 surgeries on top of those multiple cystoscopies that resets the clock. And so you're really talking about, a minimum of at least 4 procedures a year. I think thinking about how we can de-intensify the need for surveillance there is really interesting. And so if you have a tool that allows you, without a doubt, to be able to say that if this test is negative, the likelihood we've missed a high-risk cancer is essentially vanishingly low. So these new tools like CX Bladder Detect now, so that the surveillance tool as opposed to the detection tool, as opposed to CX Bladder Triage, and also the Expert Bladder Cancer Monitor. So that was evaluated in a recent study that was also published. It's the DeBlaca 15 clinical trial that demonstrated that you could replace cystoscopies without an increased risk of missing tumors in that patient population. So I think that definitely in the high-risk patient population where the burden of this disease is already so high, if you could safely use a biomarker to decrease the intensity of the surveillance, I think that would be very beneficial to patients. It's also a big patient population. But then I also, where we really are lacking in effective markers is in the identification of the biomarkers that identify low-risk disease. I understand that, and I know I've lent my voice to the debate about the fact that we probably need to de-intensify how we manage low-risk disease and intermediate-risk disease in terms of the fact that we probably can surveil some of those patients. So identifying those tumors right away is probably not always necessary. We can switch our treatment modality from in operating room to in office, whether it's biopsy and fulguration or even, and we're really excited about moving towards this era of ablative therapies. But I think that actually, I don't know that there's one patient population I want to reduce the cystoscopy requirement, and I think I'd like to reduce it in all of them because patients really, they would benefit from that globally. But I think that it points out that we especially need tumor markers that can identify sort of tumors across the spectrum. So that's where we are going to need bigger and better biomarkers that actually can accomplish that.
I agree with all those points. Now, in the high-risk NMIBC patients, let's say we're not thinking about getting rid of cystoscopy, we're just trying to augment it and really hunt down recurrence as soon as it happens. We have all these new fancy treatments that we can use. We want to try to use them earlier. Do you think there's any biomarkers that are ready to use now or close to ready to use now in that kind of setting?
I would be hesitant. I think of you're saying replacing cystoscopy?
No, to kind of augment
or augment cystoscopy. Augment my cystoscopy and my cytology. Maybe the AI-based things, I think is probably the most promising in my mind, from that aspect, maybe some ctDNA, but I'm not going to change my practice tomorrow in doing that necessarily.
Maybe it's an opportunity, though. I think all of us are pretty frequent blue light users. Yeah. And I think that that's where I think...
That's a biomarker, right?
Enhanced cystoscopy is another biomarker.
Yeah.
I consider it a biomarker. I think in those high-risk patient populations, I definitely fall back on using that to make sure I'm not missing anything. My personal preference is for patients who have, especially if they have a history of carcinoma in situ, that not the 3-month mark. So after induction BCG, not at the 3-month cysto, but at the 6-month cysto. That's a for-cause. Go to the operating room with blue light, random biopsies, make sure we're not missing anything. I do want to make sure at that point, because that's when you're really making sure you're not missing a BCG unresponsive tumor that is sort of either persisting or developing. I want to understand that. But I think at the 3-month mark, it might be a little bit early because some of those patients just need a little bit more immunotherapy. And I think there's people who sit on both sides of the fence saying at 3 months, do you need just another round of 6, or can you get by with, especially in the BCG scarce world, can we get by with a maintenance round at that point? And I think many patients can be rescued with that initial maintenance course. So getting people through their immunotherapy to the 6-month and then using the enhanced cystoscopy to be sure that you're not missing anything is very helpful.
I think that's a great point, right? There's this polarizing, and this is where the grayness of non-muscle invasive bladder comes in, right? And we have these guidelines and we have these very strict definitions of what it means to be BCG unresponsive. Yet we see these patients that have had BCG and you re-look in, right? It's that 3-month mark where they have a therapy and, you'll see a little bit of redness or you see something. I don't jump on those patients right away, right? But it does require you to have that upfront conversation with them and explain what that is. Meaning I'll give them some time, I'll keep treating them. And really that 6-month time frame is where I pull the trigger. Now, it does come down to a lot of experience of saying, okay, would I say that for everybody? If the whole bladder looks terrible versus, a single spot, right? The patient's age comes in, their comorbidities, are they still smoking, right? There's a lot of things that are kind of going through our minds, whether or not we realize that or not. But I'm not the early 6 weeks you finished, I see a little bit, I'm going to biopsy it, see if there's still CIS, and oh, you failed, let's move on type of person.
Yeah.
But I know people, if you're reading guidelines, right? And so I do end up having that complex conversation sometimes with patients. And they say, but wait a minute, should we switch to chemo now or should we switch to something else?
Yeah. No, I think there's 2 really good points that you made. One, if you really want to find cancer, blue light is probably a better way to do it than office cystoscopy. Yeah. And should we have a set time where we decide that's what we're going to do, especially if a patient's had a lot of prior treatments before? And then the second thing is, do we really want to find cancer as early as possible in patients getting immunotherapies? And, I'll tell you, I have a little bit of a philosophical difference there.
Okay.
It used to be we just had BCG. We knew that giving additional BCG maintenance or reinduction is going to convert maybe 50% of patients with positive cancer
Rescue.
at the 3-month time point. Now we have a whole slew of alternative options. So to me, finding that little bit of cancer, maybe we can get them started on another treatment earlier just to prevent a big recurrence in the future.
I hear you, and I get that, right? But although we do have this plethora of new things and they will continue to come out, these patients are, we know what the future looks like in the destiny, right? How quickly do we want to progress through those things? I might make the argument, then if we really think that, then should we just be really saying, you need an early cystectomy? I'm not arguing with you. I'm just kind of pushing a little bit of questions that come up in my mind.
Worthy debate.
Yeah, I think so. I probably come down a little bit on Katie's side here, just because I talk to patients about if someone is, and this is different, if they are a cystectomy candidate and they are open to an early cystectomy, then that's a different story altogether. But for patients who have made it very clear that bladder removal is not something that they are willing or able to entertain, and we need to stretch out our bladder sparing options as long as possible. I sometimes talk about trying to squeeze every last drop out of that drug and keep everything else in my back pocket for when we're going to need it next. But it's a very individualized decision-making sort of process. And I think both your points are extremely well taken. We have new options. So if something's not working, the definition of insanity is doing the same thing over and over again and expecting a different result, right? But on the other hand, if it's one of those gray zones and it's a little bit of CIS, I think your 6-month mark is your go, no go. I think that's where you actually need to put your money where your mouth is and say, this is not working. We need to shift. Sometimes I think you can rescue a few patients.
And patients are all a little different. Some
Absolutely.
fall in one camp and the other. Some like the idea of a new treatment. Others want to give it a little bit more time. So we have to take that into account too.
Yeah, absolutely.
You also mentioned this earlier, cost. So, these biomarkers, they're going to cost somebody money.
That's right.
How do you think about that when you're considering what tests to order?
Yeah, so, I do think, cost is huge, right? Bladder cancer is the most expensive cancer that we treat, and a big portion of that is potentially non-muscle invasive, and even with that are not high risk non-muscle invasive, right? So I think we need to be very, very cost aware in that patient population, right? In these low grade, intermediate risk categorization. So love the idea of avoiding some cystoscopies and doing all of these things in theory, but the impact of cost, I do think is important. And if we're thinking about, where you're going to spend money, are you spending money on diagnostics? Or are you spending money on therapeutics? Or are you spending money on both, right? And that's a hard thing to wiggle out, and I think looking at it from a big picture is one thing. And then I walk into the room and I'm sitting with a patient right in front of me, and it's really hard, right, to think that cost has any impact whatsoever in kind of a decision-making process. But I do think our practices are looking at it, our hospitals are looking at it, and it does get weighed out. I don't know where it's going to fall.
I think
it's tough.
The financial toxicity piece is so bothersome. But I guess where I come down on it is if a biomarker is going to help me make a better choice to identify that for that patient, the treatment that's going to help them the most, that is likely to get them on a path where they become disease-free, they have a CR, that means they're going to be on quarterly cystoscopies for a shorter period of time. That means they're going to be less likely to be in the operating room. So where do we save money with biomarkers? We keep people out of the OR. We get people the treatments that work. We don't do things that don't work. And ultimately, you save patients a cystectomy, which is the most expensive. The tricky part is if we're ordering tests that aren't going to change what we're doing. So I guess this goes back to what we said at the very beginning of this podcast. If a tool is going to allow you to make a better treatment decision, then I think it makes a lot of sense to do it. If you look at for example, just those screening papers that I mentioned, there are some cost analyses in them where they basically demonstrate the cost savings by having patients not get white light cystoscopies that would have identified a normal bladder. So you're saving a healthcare system there a ton of money. But on the other hand, if we're just ordering tests and saying
still doing a cystoscopy,
interesting, and doing the cystoscopy, and then we're getting more tests that are not changing what treatments we're choosing, then we are just compounding the financial toxicity of this disease.
Yeah, really good points. Yep.
I think, as I think about this and I think of all of these tests and things we have is really putting in or ordering a test that can put a patient down an appropriate pathway, right? Let's go back to kind of the, histopathology with AI, right? If it can tell me that your tumor is going to be way more responsive to gemdosi and you're going to get a 2-year high-grade recurrence-free survival of 20% better with gemdosi versus BCG, then that's a huge impact, right? There's two things, right? I save the cost of putting the patient through the BCG so that they have to then ultimately end up failing that before I can give them the gemdosi. It saves my BCG to give to another patient who might be more appropriate. And then that impact that it has on the patient, right? And so that cost up front from a big system, you think, yeah, I'll take that all day long.
Yeah, that's a nuanced point. So essentially, if the biomarker is able to make an impactful difference, the cost will kind of pay for itself.
Mm-hmm.
So if I could have you make a prediction, when do you think we're actually going to see these biomarkers able to guide treatments and truly give us precision medicine? Do you think it's a year away, 5 years away, 10 years away?
I would say in the next 2 to 3 years that we're really going to be honing in and really making these decisions. I mean, I have no crystal ball, right, in front of this, but just based on the fact, right, if you would have asked this a couple of years ago, right, we were a little bit more in the dark ages, not quite understanding where these things were, but also proof of principle in clinical practice means a lot, right? If we think about Signatera, right, Sarah talked about it. We see it in our muscle invasive patients and the metastatic patients, and we see how it's impacting clinical decisions. So, extrapolating that and then making us more comfortable to use it. I would say 2 to 3 years.
Yeah, I hope so. I'm going to set my calendar for 2027. I'll call you.
We will meet back here for this podcast.
Is there any last final thoughts?
No, I guess the only other thing we haven't really talked about, though, is what's the patient experience of having biomarkers, having that extra information. To your point, I think sometimes the biomarkers allow us to provide a little bit more nuanced information that might help a patient feel more comfortable and reduce their decisional conflict. Like if it's a high-grade T1 patient and they are making that decision, cystectomy versus a bladder sparing option, having CHI, AI data to back them up and say, this is a really bad actor, having the Decipher score to say that this is a non-luminal tumor, we should probably be thinking that there is a major risk of non-organ confined disease here, or that there's a higher risk of upstaging. I think that can be really helpful. But a lot of times what we end up with are false positives. And so that just does, goes back to the very first thing we talked about here, which is that we see a lot of referrals for positive biomarkers without a clinical correlate. And I think that navigating that with patients is really tricky. We don't necessarily know what the biomarkers mean. We know they're not perfect, but the patient is sitting with a test that says your risk of bladder cancer is positive. Yeah. You have, it's essentially a positive test, but not a positive test. So I think that we do have to, again, just come back to the patient perspective in all of this and think a little bit about every time we order one of these tests, we could get a false positive, we could get a false negative. But I think that we have to couch that and we have to counsel patients about the fact that these are not perfect. The gold standard is the biopsy. So got to think about that.
False positives impact patients, but I was, as you were saying this, I was just thinking false positives impact us, right?
Yeah.
I mean, the amount of time I've spent stressing over, am I missing this? Where is it at in the upper tract?
Cancer?
Where is it at in the bladder? Did I miss a time frame in my blue light that where is this, right, of this gut filling, it's impactful to us as well. So it stresses out the patients and then it stresses out the providers as well, meaning even that patient, you keep going back and thinking, last year, though, they had that positive, right? It still kind of lingers in on us as well. So,
and I think to that point, just going back to it, I mean, there are a lot of patients who you end up with a positive cytology and totally negative cystos and upper tract evaluations. And it's tough. But I think that's why we need better biomarkers to figure that situation out and understand, is this real or not real, and what are we missing? I am really excited as to where this is going to go in terms of helping us appropriately escalate and appropriately de-escalate care so that we actually are kind of giving people what they need.
Yeah, that's really well said. A very exciting field. I think a lot's going to happen in the next couple of years, but we have to think about cost and the patient perspective also, keep that at the front. So it's been a great discussion. Thank you guys for joining.
Thank you.
We'll chat again soon.
Until next time.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.